I'm going to talk about the situation that we've seen in the UK and how that's unfolded inequalities wise, kind of present some of the work that we've done evaluating some of those policies, and then try to reflect on some of the politics of health that we've engaged in over that period. Nick and Louise, we know that INRICH is the best conference. This is us at the end of the conference last year in Paris, plotting the revolution in a left bank bistro with colleagues. Pretty laid back then. But almost the next day, I got an email from the UK COVID inquiry asking our research group, Health Inequalities Policy Research Group, to put together a report for the COVID inquiry on inequalities in children. So I'm going to pick up on some of the data in that report to outline kind of the situation we find ourselves in health inequalities wise for children, picking up on the story that Kitty outlined. So I'm going to show some health outcomes. This shows infant mortality by decile in England, and you can see here the gap. This is the absolute inequalities gap. In these graphs, I'm putting a line at the change of administration around 2010, where we've got data going back that far. But you can see that inequalities in infant mortality were reducing, and then they started to increase, such that in the latest OECD ranking, we're 29th now. We've continually fallen down the rankings. We're catching up with Canada and the States, and the countries on the far right here are Costa Rica, Mexico, and Colombia, with very high levels of infant mortality. And in the report, we outline some of the intersectional influences on infant mortality, which are important to point out. So this plot shows data over the last 4 years, a 4-year period in England, and shows the socioeconomic gradients in most ethnic groups, apart from for Black women, where the infant mortality rate is the same regardless of index of multiple deprivation. Infant mortality rate almost 8 in for children born to Black women in the UK. This shows obesity. Kitty mentioned trends in obesity. This is 10 to 11-year-old children from National English data, showing that pre-pandemic inequalities were rising, gradually rising for 10 to 12-year-old children. And there was a big jump in the pandemic, which has recovered, but it's recovered particularly for the most advantaged group. We see a similar picture for mental health problems. This is from our Child of the North report, which shows probable diagnoses of mental health problems in children under up to age 16 by deprivation quintile. And you can see the rise in absolute levels and the rise in inequality over the period of the pandemic. We've been looking at looked after children. There's been a dramatic rise in children taken into local authority care over recent years. It's particularly happened in the north of England, so it's a big public health issue where I work in Liverpool, and through Health Equity North, which Kate Pickett, myself, and Claire Bamborough and Luke Mumford in Manchester lead. We've been doing a number of reports on specific areas where inequalities are getting worse. Something we've been working on at the moment, which is particularly shocking, is looking at inequalities in vaccination uptake. So we're seeing outbreaks of pertussis, whooping cough at the moment in the UK. And this article in Press looks at inequalities in all of the major childhood vaccinations. I'm going to zoom in on this, but you can see the general picture by deprivation quintile in England. But if you look at the 6-in-1 vaccination, which covers pertussis, whooping cough, you can see there's been, over the period of the pandemic, there's been significant rise in the absolute level of inequality. Almost even in the most affluent areas, we just about touch 95% coverage. It's particularly stark for measles. So all for MMR1 vaccination, all areas are below the 95% WHO threshold. And the absolute inequality in percentage points increased from 5 percentage points across deprivation deciles to 10 percentage points over a short period of time. As Kitty's outlined, we've seen a dramatic rise in child poverty over this period. In the latest UNICEF report, UK came in near the bottom, almost at the bottom, 37th. That was based on actual child poverty and the change in child poverty over the recent decade, essentially. So here, this shows the change in child poverty from 2012 through to 2021. According to UNICEF, the UK has seen the biggest increase in levels of child poverty. Notably, as we heard yesterday, Canada has seen a similar decrease in child poverty, almost the same magnitude in the opposite direction. So I'd say, these type of changes are really important. It's really important as a community we evaluate the impact of that Canadian reduction on health outcomes. We've done some of the work looking at the impact of that change in poverty on children's health outcomes, and I'll come to that shortly. This is another horrifying graph turning to adult health of significance for children. This is maternal mortality since 2010. We've seen a big increase in maternal mortality, particularly affecting the most disadvantaged women. There are also large intersectional inequalities, so it's particularly affected poor Black women. And as we've rehearsed in INRICH previously, this happened at the same time as first of all, a stalling and then a reduction in life expectancy. So we're used to life expectancy increasing year on year for males and females, but it's started to stall around 2010 and then has gone backwards during the pandemic. And in the data just prior to the pandemic, it was evident that the change in life expectancy was going backwards, particularly for women in the most disadvantaged areas, which obviously is a bad omen in terms of children's health, if you believe that maternal and child health are intrinsically linked. So that's a picture, a depressing picture of health affecting children and adults in the UK. The problem was one that was foreseen fairly early on. I mean, if you look back to 2010, it coincided with the publication of Michael Marmot's Health Inequalities report for the UK that set out a whole series of very sensible recommendations, the most important being to focus on children's health. And almost as soon as that report came, it was commissioned under a Labour government. It was enacted by the coalition government, and we saw massive austerity in response, on the back of a report saying do the opposite. And as Kitty's shown, particularly affected. This is in this line here. This is local authority budgets. Essentially, this is the welfare budget, work and pensions. There was a real term. There was an increase in health, but that was mainly due to acute demand-driven level factors. And going back, there was lots of good work predicting the impact of this. So this is in 2012. Nice report from the Institute for Fiscal Studies looking at the projected impacts on children. So the report said these are colossal cuts, raising the question, is this a fundamental reimagining of the role of the state? In 2013, we did some analysis looking at the cut per head to local government budgets mapped it here against premature mortality in the population, again showing the regressive nature of these cuts. The sickest areas had the biggest cuts to their budgets, and the cuts particularly affected services for children. So we've been following the money across different budget lines, and this shows the change in spend by deprivation quintile on early years prevention for children, showing that we moved to a more per capita resource allocation formula. So deprivation was de-weighted across formula in health, social care, education. And again, the IFS, it's a report from the IFS, around 2012-13, predicting what would happen for children. So it was clear very early on that these this is the big reduction that we'd seen in child poverty, and then the predicted increase. And indeed, that's exactly what we've seen, as Kitty has shown. There's another report here from our Children's Commissioner. It was Anne Longfield at the time for England in 2013, showing that the combined impacts of the benefit changes were regressive and particularly impacted children in the poorest areas. One of the first things we started to see were cracks in the kind of social determinants of health, child poverty rising. We saw food poverty become a phenomena in the UK. We'd never had food poverty. This wasn't a thing that people talked about. It's become part of the furniture now. At the same time, Sally Davies, the CMO, Chief Medical Officer at the time, said she was ashamed that rickets were making a comeback. So there was a headline, this was 2013, on the back of that, the rise in food banks in England. So the Independent said food poverty was a public health emergency. If we jump forward to now, 2024, Rachel Loopstra, who's in our research group, wrote an editorial in the BMJ last week, and the latest data shows that 2.4 million, 17% of all kids are food insecure, and she argues that the UK's children arguably face higher levels of food insecurity than either Canada or the US. So this is a completely new, this is a decade, this has happened over the period of a decade. It's quite incredible. So what caused these trends in inequalities that we've seen? Well, I guess, I've described the rise in poverty. You see this big reduction in poverty, and Kitty's spoken to this already. It's important to go back to what happened over the period 2000 to 2010, when New Labour implemented the English health inequalities strategies, which is kind of widely regarded as the largest experiment in the world in tackling health inequalities. We've written about it in this book with Gordon Brown, and it was a cross-sectoral focus on targets, resource allocation, the establishment of Sure Start, so a focus on early years. Sure Start established proportionate to levels of need. There were focus on area-based regeneration, also better management of chronic diseases in adulthood. And I was training in public health in Liverpool at the time, and we did set up children's centres in the most disadvantaged areas to begin with. There was a focus on the wider determinants of health. There was a healthy homes programme and a focus on the NHS and anchor institutions and how they could boost employment in local areas. Did it work? Well, to cut a lot of research, to cut the story short, well, it did. And I think these two analyses are really important. They're from Margaret Whitehead and Ben Barr and Claire Bamborough, showing that trends in inequalities before, during and after the strategy showed that it had an impact on reducing the targets, which were around life expectancy and infant mortality. And then much of the work that we've done subsequently has looked at the kind of unraveling of that situation. As soon as action on poverty was reversed and austerity kicked in, we've summarized some of the evidence here in this blog. What did local government ever do for us? And we've collected a lot of the data on spending at local area level in England, which we've used to evaluate the quasi-experiment of austerity over time. So this analysis looked at poverty and infant mortality and showed in, using quasi-experimental approaches that that poverty led to a rise in infant mortality. So we calculate 600 excess infant deaths over a 3-year period, above and beyond trends that we would have seen if poverty hadn't increased. In terms of children entering the care system, these analyses showed a causal effect of rising child poverty on children entering care. In this analysis, we calculate 10,000 extra children entering care over a 5-year period at a huge cost to the public purse and obviously to the children who end up in the care system. We've looked at different budget lines. Just to give you a few examples here, this was analysis that looked at the impact of cuts to early years spending, essentially spending on Sure Start, and how that's impacted inequalities in obesity in England. And again, we show a causal effect of cuts to Sure Start on increasing obesity bigger in the most disadvantaged areas. And this analysis here looks at the overall package of local government spending and the contribution of that spending to trends, those trends that I showed in life expectancy. And we show that cuts to local government spending made a significant contribution to the adverse trends in mortality that we've seen in England over the period. So I presented increasing inequalities, some of the evidence around causal effects of cuts to different budgets on outcomes. Now, I'd like to make a few comments on kind of, I guess, the politics of health. My boss for a long time, Margaret Whitehead, and friend and colleague, did her valedictory lecture. We organised that at the end of last year, and you can listen to Margaret's talk. She reflects on experiences with the Black Report, and this is a slide from Margaret's talk about obstructive political tactics around disregarding or burying bad news, dismissing research evidence, discrediting evidence, and distracting and deliberately misinterpreting. So a couple of weeks ago, we had some of the evidence that Kate and myself have pulled together through Health Equity North, presented to government in a Prime Minister's question. So we have these, this is part of the ritual of politics where we have these questions every week. And Emma Llewellyn-Buck, who's an MP who chairs the all-party parliamentary group on Child of the North, presented some of the data on looked after children and increasing infant mortality. And our Prime Minister, who wears a suit that tight, our Prime Minister just dismissed the problem and said that he was proud of the government's action on child poverty. So dismissal of the problem. In 2015, when child poverty began to rise, we saw the government try to redefine what child poverty is all about. So there was a move to redefine child poverty not as being about income, but as being about parental behaviours, etc. And I know Kitty and myself and a number of people were involved in kind of trying to advocate against that change. And the government did continue to measure income poverty, which has been really important for much of the research that people have done. When it came to the plateauing of life expectancy, this was a big story, and the things that were happening with infant mortality pre-pandemic. much discussion in public health circles, but the government didn't seem to want to do anything about it. There was pressure from the newspapers, from the BMJ, and eventually there was a report commissioned into the trends in life expectancy, and I was given an early various people were asked to comment on this. It's been published now in 2018. You can go and have a look at that document, and I think historically it's very interesting to go back and look at the explanations. So there was huge effort put into suggesting that the adverse trends in outcomes were due to ambient temperature. They could have been artifactual. They could have been due to migration. They could have been due to seasonal flu, etc. And then there was a short paragraph in there saying certain people have reported an association between trends in mortality and changes in public spending and health and social care provision. So it was very much talked down as if this wasn't the likely reason. I think the overarching narrative now is that most people are agreed that this is the reason why we saw those trends in England. I guess just commenting on public health policy, we saw lifestyle drift in policy. We saw the invention of precision public health. I know Sharon's maybe a fan of this terminology, but rather than focus on the determinants of health, the government said that, if we only have better data through wearables, etc., maybe we'll be able to tackle some of these inequalities that we're facing. So I would argue this was lifestyle downstream drift in public health policy. It has its zenith maybe in the idea that if we genome screen all of the kids, which looks like it's going to happen in England, then that will help us tackle inequalities. There was a lack of a coherent public health voice. This was an article in The Lancet from an esteemed group of public health colleagues. There was a meeting organised at the Wellcome Trust. Nobody from the north could get to that meeting because all of the trains were cancelled. And this was a report from the meeting, which outlined potential reasons for the trends that we were seeing and how to tackle them. And I would argue that it was very behaviourally oriented. It focused on tobacco, diet, alcohol, physical activity. Many of those trends were moving in the right direction at the same time as these adverse trends in life expectancy. And Margaret and Ben and I wrote in response to that in The Lancet that it's time to acknowledge the elephant in the room, the causes of the disturbing health trends in England, and to design appropriate policies to reverse them. And we said we'd seen rises in child poverty, homelessness, food poverty, deterioration in mental health at a population level, reversal of investment in public services. And then finally, we saw the dismantling of public health as we know it in the UK. So in the middle of the pandemic, Public Health England was taken apart. And various charities, the King's Fund, Health Foundation, said that there's a lack of evidence behind this decision. It had an increased emphasis on infection control, and they argued that it could lead to a loss of focus on other areas of public health, such as tackling inequalities. The Office for Health Improvement and Disparities was named after Public Health England. So the use of inequalities, disparities, I know that crosses the Atlantic Ocean, but in the UK, we've used the term inequalities for a long time and prefer to use the term inequalities, but we were kind of banned from talking about inequalities, and they were renamed disparities. And the UK Health Security Agency was set up to essentially deal with anything about infectious diseases and biological threats to health. So health became more about security, and the term public health has been completely removed from any government agency. And as predicted by the King's Fund, we've got no strategy now to address inequalities. many of us were involved in the white. There was a white paper coming forward, but it was pulled. It was pulled by the government. This is a quote from a minister. The disparities paper is toast. My understanding of why they've pulled it is ideological. The white paper is an affront to this government's view of what makes for health. So what do we do about this challenging situation? I'm optimistic at the moment because we are on the verge of change. And I put this slide in before I saw Kate's slide yesterday, but I think it's important to reflect on the extent to which, certainly in the UK, we've managed to keep a focus on the wider determinants of health, because medicine's a social science, politics, nothing but medicine on a grand scale, according to Virchow. And we've, as I've said many a time, we've got reports going back to the 80s from the Black Report, from the Health Divide, through the Marmot reports, through the work that we've done on Due North and through Child of the North, all making the same recommendations. You know, it's clear that now's not the time for more research, it's the time for action in terms of reducing poverty, reinvesting in services proportionate to need, listening to children's voices, taking a children's rights-based approach, and obviously systems need to act early, act on time, and act together. And I am optimistic for change, and Gordon Brown in the UK has been leading the way in the media, at least, and has outlined a renewed strategy to tackle child poverty, as he did through 2000 to 2010. This is Gordon Brown in a multi-bank in Fife. So to finish, this was a quote from an article I wrote in 2019. It was just in response to the personalisation agenda. Finally, let's not forget that money is the ultimate personalised medicine. Parents exchange it for health-promoting goods and services such as better housing, better clothes, healthier food, and life-affirming trips for their children. Thanks for listening.
David, I'm kind of crossing the things that you said with what Kitty said about what's happening in the UK. And I was very struck by a couple of things. One is the concordance between the idea that things changed as political parties changed, that nomenclature changed over time, and that you have these standing reports over time that haven't kind of gone anywhere. And I wonder if there is a story you would care to suggest, a meta story kind of going across these talks about how this happens. And I think to Heinz's earlier point about politics and voting, is there something that you can see in these patterns that you would suggest as a meta narrative of what has happened over time?
I guess I was really trying to think of some of those lessons that we've learned as to why some of the research and the reports, endless reports, haven't cut through. And I guess one of the things I found fairly striking when we pulled the report together for the COVID inquiry was the clear picture, no matter what health outcome you looked at, of stalling, worsening inequalities. It was very, very consistent. I know Danny Dorling, who's, I don't know if he's doing a talk or showing a video, he's got his peak inequality theory where, he says essentially politics swings one way and then the other, you reach peak inequality and then policy has to change. And I guess it's become so that you can't ignore now what's going on in the UK, because, partly because the data's there, but partly because it's very difficult to run a country in the face of these very worrying trends. But as to, I guess the question that concerns me is what could we do differently, and why hasn't some of that evidence cut through? We've been, Kitty and I, involved in Child Poverty Action Group, and I know, speaking to some MPs, there was the idea that the story, the kind of story of the success of the English health inequality strategy and the Brown-Blair action on, it just wasn't packaged and marketed in a way that cut through. And it was very easy for George Osborne to dismiss all that progress with the big idea of austerity. And so people have almost ignored that evidence. Where I think it's very, the example of the UK, the N of 1 study of the UK, of certainly over the last, 2 administrations, where investment and reducing poverty reduces inequalities across all aspects of health, doing the opposite. I guess thinking about the future, how do we make sure that we can mobilize that so that we get better policies? And I don't know, I don't have the complete answer to that, but I think some of the work that we've been doing with children and coupling the evidence with children's voices and case studies has been very edifying. So the work we've done with Health Equity North, with Kate Pickett, etc., that's been very useful.
David, that was a fantastic talk. I just on a more optimistic side, across the European Union, they've voted to introduce a European child guarantee to improve healthcare, education, nutrition, and housing for all children within the European Union. Do you think a new government could be persuaded to adopt that in the UK?
I think so, and I think that's what we need to do, and that's our job, isn't it? And I noticed that Keir Starmer was talking about reducing the voting age as well. I think, giving children and young, the issue of agency and voice in these issues is a really important one. And is it simply the fact that children are a disenfranchised group and don't have a voice that means they're easy pickings? You'd have thought that wouldn't happen, but that data on prevention, the first thing that gets cut is our preventative services for children in the UK. Whereas if you present this data in Copenhagen, for example, they say that would never happen. Nobody can cut preventative services for children. It's just not part of, somehow there's a culture where things like that would be unacceptable. So I think that there are all sorts of things that we need to learn from what's happened, and I don't have all the answers, I'm afraid.
And in Copenhagen, they have a conservative government most of the time. Yeah.
Mm-hmm.
Okay, I wanted to look at some of that comparison. Particularly, I know you've worked with colleagues in Denmark quite a lot, but for it's very interesting to what we've done this morning in a way. Not Arjuman exactly, but Kitty and you, David, have looked at the UK as a case study in which these enormous swings in social policy have taken place, which have allowed you to make these very detailed analyses of health inequalities during those different periods, and to look at the issue of funding and so on. But I think it'd be very interesting to have some comparative stuff in countries that haven't, or some countries that have experienced austerity in the way that we did, and some that didn't. And we certainly did some looking at this with the Spanish colleagues, with Luis Rachmil and Anders Jern in Sweden. So thank you very much for that, both of you, Arjuman and David and Kitty. That was a really excellent morning. Thank you.